Hello and welcome to another Piper Pod. Today we're going to continue with the pathophysiological theme and we're going to look at the gastrointestinal system. Now the gastrointestinal system is a very complex system. It involves obviously all the digestive tract right from the mouth all the way through to the anus, but it also includes a bunch of accessory organs as well. So when we start looking at pathophysiology, it could include thousands of disorders. So today we'll just do an overview of a lot of the common, and we'll look at each particular organ along the track, if you will. Now when we talk about the gastrointestinal system, we need to remember that the whole function of the gastrointestinal system goes in line with digestion. So everything to do with ingestion, digestion, now that's both mechanical and chemical. So mechanical being mastication and deglutination, which is another way of saying swallowing. And then you've got your chemical digestion that occurs in the presence of acids, enzymes, and pepsinogen as well. The absorption of nutrients and fluids is also taken care of by the gastrointestinal system, and the importance of excretion, obviously via feces, is another main function. So when we start looking at pathophysiology, it's anything that involves or interferes with any one of these steps. So as you could imagine, like I mentioned, there are thousands of possibilities, but we'll start right at the top and we'll look at disorders of the esophagus. So the esophagus is a smooth muscular tube. It's about 25 centimeters long, and it transports from the mouth all the way to the top of the stomach. Now, the esophagus has a sphincter that sits just above the stomach, okay, and that's called the esophageal sphincter. It's made up of muscle fibers that interlink like a woven mesh. And we also have what's known as a diaphragmatic sling that runs over the top of the diaphragm and helps hold the sphincter in place. Now, one of the disorders that can happen is known as a hiatus hernia, and that's where part of the stomach actually bulges out. So it's the placement of the stomach from the abdominal cavity into the thoracic cavity. Okay, so what happens is it moves through this diaphragmatic sling and it pops out over the top. So you can either have what's known as a sliding, where just a portion of it slides all the way up, or you can also have a paraesophageal, which is also known as a rolling one. And that one's a little bit worse because it's more associated with reflux type damage as well. Now, both of these hiatus hernias, they alter the function of the lower esophagus and lead to an increased likelihood of reflux itself. Now, the second one is achalasia, and achalasia is just a spasming of the esophageal sphincter. Okay, so it's stenosis of the esophageal sphincter, and it's often got to do with a failure for that sphincter to relax. So as it contracts down in order to prevent reflux, it never essentially lets go, so it just keeps relaxing. Now this leads to, or can lead to, an inability to swallow food, or dysphagia. Because there's no food in there, or a reduction in hunger, can lead to weight loss as well. And if it goes on long enough and it's quite chronic, then what can happen is the actual esophagus, the proximal end of the esophagus, can dilate to the extent that you'll end up vomiting food and fluid, but that's just associated with what's found in the esophagus itself. Okay, so it's quite an interesting condition. Now, achalasia and hiatus hernia can both lead to something known as esophagitis, and that is where we just get inflammation of the esophagus itself. So a common cause of that is reflux, obviously reflux by the hiatus hernia, but it also can be caused by certain infections like candidus or herpes simplex, and chemicals, so ingestion of either high acidic or high alkaline chemicals themselves. A chronic condition of reflux is gastroesophageal reflux disease. Okay, it's a very, very, very common disease. It's where you lose some form of the esophageal sphincter tone, and it ends up in an increase in gastric content, acidic gastric content coming through, causing localized inflammation. Now, certain risk factors are obviously the hiatus hernia, but there's also things like smoking, caffeine, pregnancy, anything that increases the intra-abdominal pressure, like obesity as well, is also a pretty big risk factor associated with it. Now, when these people get this gastric reflux, they feel heartburn, so it's often mimics a sharp chest pain, and a symptom then is odynophagia, so is pain when they swallow. It's got to do with irritation and ulceration of the back of the esophagus, and you'll also end up with dysphagia. So as GORDS continues to irritate and degrade the lining of the esophagus, it can have further complications. Obviously, an increase in destruction, increase in alteration can lead to a condition known as Barrett's esophagus. So Barrett's esophagus is, as mentioned, caused by a chronic case of reflux. And what happens is you actually end up with a metaplastic formation, or metaplastic changes to the squamous epithelial cells. Okay, now this metaplasia, or metaplastic, actually turns into dysplastic, and with that you end up with a huge increase in your mucoid secretion glands and a essentially unsmooth epithelial lining. Okay, so the goblet cells in the outside of your lining become hypertrophic, and they end up getting metaplastic as well, which means they're no longer linear in formation. They end up in abnormal formation. It can reduce the actual size of the esophagus and lead to further irritation itself. So a few cases of Barrett's esophageal, you can actually, during a scope, you'll see down and you'll see like a large or a stenosed formation of cellular growth around the esophagus. Now, Barrett's esophagus will actually increase your risk of carcinomas as well. So when we look at, on the left, carcinomas of the actual esophagus, this is associated with Barrett's, or as you mentioned, chronic reflux disease, and it's also closely associated with alcoholism and smoking as well. Now, when people get a carcinoma of the esophagus, the prognosis is not very good. They generally get only 2 years to live because it is very simple to metastasize. The esophagus is quite a thin lining of mucus, and it can easily transfer to the muscle, getting its own blood supply, and then leak into the lymphatic system first, very early, but then also into the bloodstream as well. So it can move throughout the body quite a lot. Now, the symptoms are very similar to reflux, difficulty swallowing, pain on swallowing, and sometimes associated weight loss. So if you have someone that's chronic or has GORDS, then it's a risk factor, and they need to have gastroscopes quite often in order to look out for formations of these carcinomas. Now, another one that we'll mention a little bit more, but this is our esophageal varices. Now, this is where vessels within the esophagus actually become dilated. Now, the reason they become dilated is because of a condition mostly known as hypertensive portal. So it's basically your portal vessels, or hepatic portal vessels, become hypertensive, and that increases the pressure found in the esophagus, and you end up with these large dilated vessels. Now, these dilated vessels are subject to rupturing, which is obviously a medical emergency, as people will bleed into their stomach. Okay, speaking of the stomach, we'll move down now. The stomach is a main reservoir. It's obviously used to aid in digestion. It uses acids and pepsin in order to digest, and is protected by a wonderful bicarbonate mucus layer to prevent the actual digestive juices or digestive fluids from digesting ourselves. Now, a very, very common signs and symptoms that you'll get with people with stomach type problems is they have like midline upper abdominal pain, vomiting, bleeding, so emetus, and then also melena you can get. Dyspepsia can be another one, and then you can also get your more chronic conditions to do with vitamin B and stuff like that. Now, quite a common state is gastritis. So gastritis can either be acute or chronic. Now, the acute ones are caused mostly by chemical ischemia and infection. So the main chemicals at play is actually your drugs. So your non-steroidal anti-inflammatories, your sacchalates, steroids, and then of course you've got your alcohol and your corrosive substances as well. Now, ischemia is mostly associated with some form of trauma. Okay, so either a lack of blood flow due to trauma or burns from actually ingesting corrosive substances. Most common infections that cause gastritis is Helicobacter pylori and herpes simplex. Now, when we start moving into chronic gastritis, we have similar causative agents. So Helicobacter pylori plays a big role, as does alcohol, smoking does as well. But other causes of chronic gastritis is what's known as your autoimmune mediators. Okay, so mediators are mostly got to do with an impaired ability to absorb vitamin B12, and then that ends up leading to anemia and other neurological symptoms. Okay, so it's caused by inflammation caused by intrinsic factors that affect the mucoid layer, which in turn stops the absorption of the vitamin B12. Now, having a closer look at Helicobacter pylori, or H. pylori, because this particular pathogen is associated with quite a few different gastrointestinal problems. So Helicobacter pylori is a very specialized bacteria that is quite common. Okay, it's in about 50% of the population you'll find, and anyone that has a peptic ulcer, it's about 90% of those personnel will have a Helicobacter pylori within it. Okay, so it's a gram-negative bacteria, and this particular one thrives in the gastric environment, because what it does is it actually uses urea as a form of organic substance that it uses, and as a byproduct it produces ammonia. Now, that ammonia itself actually degrades the lining of the gastric mucosa. Okay, and as another thing, it also lowers the pH. Okay, so by lowering the pH and basically breaking down the gastric lining, it allows itself to live in that environment quite well. Now, to make matters worse, it also has a flagellum within it, which means it has the ability to move to an area that is more susceptible, less acidic, and go from there. So it's a very specialized bacteria that uses its own inbuilt acidic buffering system, and is highly associated with metaplasia and dysplasia formation, things like carcinomas, and also the formation of peptic ulcers as well. So a peptic ulcer is just an ulcer that can form in the stomach, the duodenum, or the esophagus. Now, the way a peptic ulcer is formed is essentially it's a balancing of conditions. So it's a matter of having a balance between damaging forces and defensive forces. So when we have a normal stomach lining, obviously the stomach is filled with the ability to digest things, because that's what it does. So the acidity and the pepsinogen enzymes are designed to break down organic material, which is what we're made of. So we have defensive forces in place. Obviously we have a very structured and layered mucous membrane. We have the presence of bicarbonate, which helps protect it from the acids. And then we also have an increased surface area thanks to the lining of the stomach, in order to help spread out the damage that it will go through. On top of that, we have a whole bunch of, in the background, base membranes that are able to highly regenerate. Okay, the stomach has this huge ability to regenerate very, very easily. And last thing is it's closely associated with its own inbuilt inflammatory properties, so it can actually inflame when it needs to in order to boost protective and regenerative properties. So that's your normal state. Now when things turn into abnormal, it's when we start looking at one or two things happening. We either have an increase in the damaging forces and or a decrease or an impairment of those defenses. Okay, so if we add a number of damaging properties like a H. pylori, I've mentioned your aspirin, your NSAID, alcohol, hyperacidic states, then that's obviously going to increase the damaging forces. And if we have something that destroys our defensive system, like a reduction in blood flow, something that slows down our peristaltic motion, or age and degradation or existing conditions, then we're going to have a mix mash, if you will, and it's going to lead into the damaging forces. And what happens then is the body, the gastric juices, start digesting our cells. Okay, so they digest us, and then we end up with an ulcer. So from an ulcer, we obviously can get complications. So the first one, it obviously causes pain because it causes acute inflammation, and then that stimulates the actual nerve fibers that causes pain. And on top of that, you can get hemorrhaging in the area. So you can end up with emetus, melena, as you mentioned about, but you can also get anemia from chronic blood loss over a long period of time. On top of that is these actual ulcers, if it's in the wrong area, can leak into the pancreas and therefore causing acute pancreatitis that we'll talk about later on. You can get perforation as well. Proliferation is probably going to happen thanks to inflammation, but you can also get scarring and fibrous formation of the stomach, causing the stomach or the duodenum, or the esophagus for that matter, to actually go through stenosis. So reduce inside, only causing more and more complications from there. One of the complications that we think is associated with peptic ulcers, but the cause is pretty much not 100% known, is your gastric carcinomas. Okay, so we know that certain risk factors, like the presence of Helicobacter pylori, causing the metaplasia, dysphagia formations, is a risk factor, as well as a diet high in nitrosamines as well is a general risk factor that has been found. But the cause for gastric carcinomas is unknown. But like your esophageal carcinomas, the prognosis is quite poor. Okay, and it generally lays quite dormant, and then the symptoms appear late, and by that stage they're at the stage of metastasizing from there. Okay, moving on to the intestines and starting with the small intestine. So small intestine by diameter, okay, it's about 6 to 7 meters long. It's pretty good. It's broken up into the duodenum, the jejunum, and the ileum. Its main role is enzymatic digestion and absorption. Okay, the absorption of all the nutrients into those very specialized cells called enterocytes. Okay, now this whole thing is aided by the arrangement of villi. Now these villi help with peristalsis, but they also dramatically increase the surface area for absorption. Now on top of that, the small intestine itself also has a very large amount of lymphoid tissue, which helps in the absorption and the distribution of these nutrients around the body. Okay, so that's very, very, very cool. So one of the conditions that can occur in the small intestine fall under a category known as spirouse. Now, spirouse is a way of saying that those villi that I spoke about actually get damaged. And with that, we have a total reduction in the absorption ability of the small intestine. Now, these can either be what's known as a tropical spirouse. Now, we believe that is caused by bacteria, but we're not 100%. And then you have your celiac, which is your allergic spirouse. So, allergy to gluten causes a celiac sporoo. Now, obviously, if you think about these sporoo conditions, the clinical features that you're going to see are associated with malabsorption. So that's your weight loss, malnutrition, diarrhea, and then you also can have a steatorrhea as well, which is a formation of like fatty tissue around the area. So a closer look at celiac disease for the small intestine. It's obviously associated with an allergy to gluten. Okay, it's had a lot of popularity lately, as you could imagine, but the main thing associated with gluten is that it degrades down to a gliadine, which is a substance that actually causes the chronic inflammation in personnel with celiac disease. Okay, so the gluten will be broken down into gliadine, and that's what is absorbed into the bowel, and then that causes a autoimmune response, if you will, to that, which ends up in causing chronic inflammation and damage to those enterocytes. Okay, the enterocytes that are found all over the villi themselves. Now, people with celiac disease, it's not just a matter of having a slight discomfort due to inflammation, okay, because inflammation can occur from gliadines by themselves to aid in the actual digestion. What happens in celiac disease is that chronic inflammation can actually spread throughout the body and start affecting other organs and end up in chronic malabsorption as well. Okay, so that's a breakdown of your celiac disease. Now, when we look at the large intestine, okay, it's about 1.5 meters long, and its main role is to absorb water. Okay, it's also associated with bacteria and the formation of vitamin K, but its main role is that absorption of water. So a particularly large disease of the large bowel is what's known as your inflammatory bowel disease. Now, this can be broken up into two distinct different diseases. The first one is Crohn's disease. Second one is ulcerative colitis. Now, both of them are characterized by reoccurring inflammation. Now, the cause is not 100% as well. Okay, I think it's mostly got to do with genetics, but the clinical features differ slightly, but the similar ones that you'll get is your diarrhea, fever at times, abdominal pain, bloody stool, and weight loss. Okay, now, you can be clinically suspected, but you need a colonoscopy and a biopsy in order to diagnose it. Now, looking at our Crohn's disease first, it is a distribution disorder that can affect anywhere from the mouth all the way to the anus. But the most common spot is the small intestine, but it can affect the large intestine as well. Now, when Crohn's disease comes along, what you do is you end up getting a shallow ulcerative area of the intestine wall. Okay, so it's not the entire intestine that gets inflamed, it's a small segments as it goes along. Now, this inflammation can lead to a perforation of the bowels, but as it continues along in its chronic state, what ends up happening is you end up with what's known as a cobblestone appearance. Best way to describe that is you'll get little pockets of inflammation, and then you also get coupled with areas of strictures as well. So strictures are narrowing of the actual bowel themselves. So you'll have a mixed match of inflammation, little pockets of inflammation with strictures, and then on top of that you can also get adherence, the formation of fistulas that can turn into intestinal abscesses as well. Okay, so obviously the complications are chronic inflammation, which stops absorption. You get strictures, which means you have a huge problem with constipation, and fistulas that can actually move out and end up adhering to other parts of the bowel or the bladder itself, or even with the skin as well. So it actually creates a channel in which fecal matter can move into these other places. So it's quite a nasty disorder. And if you look at it under an autopsy, you'll see a very disformed bowel that will look like stepping stones all over the place, with mixtures of narrowing and cuts all through it. Okay, so it's quite distinct if you ever see it. So Crohn's disease is one of those ones that stays around long term and ends up with a myriad of problems, mostly complications and also malabsorption of water, as well as quite a lot of discomfort as well. Now the other one, ulcerative colitis, is a little bit different. It is inflammation of the bowel, and its distribution is mostly the large intestine, but if you have it, it always includes the rectum. Now this one is generalized inflammation and ulceration of the actual mucosal layer itself. Unlike Crohn's disease that affects the entire formation of the wall, ulcerative colitis is more associated with the inner endothelial lining of the large intestine. So when it kicks in, you can end up with small polyps. So it's not the whole area, but small polyps of inflamed area, and that particular part becomes thin and then predisposed to dilation. And when you have those dilatations, within the bowel, you end up with a possibility of something known as toxic megacolon. Okay, so that is just defined as sudden dilatation, pooling area within the bowel itself. So because they're relatively similar, just to show you a representation of how they differ, we have a normal one. When we look at Crohn's disease, we have narrowing stenosis of the entire tissue structure, and also an increase in our visceral fat around the actual bowel itself. So it's very, very narrowing side of the house, whereas ulcerative colitis is more of a thinning of it, an ulcerative thinning of the actual bowel. So you'll end up with different signs and symptoms as well. So toxic megacolon, for example, isn't associated with Crohn's disease, but is associated with ulcerative colitis. The distribution pattern is very different as well. Crohn's disease is pockets all the way from the mouth down to the anus, whereas ulcerative colitis starts at the rectum and spreads up in varying percentages around the large colon itself. So talking quickly about the diverticular. A diverticular is a outpouching formation. So the way it works is, as you get older, it's quite common in elderly people, your bowel has areas of weakness. Now due to the pressure within your bowel, it can cause this outpouching, or a part of the bowel to form out and stretch out like a balloon. Now these ballooned out areas are called your diverticulars. Okay, so they occur at the weakness of wall, usually associated with where your arteries come in and where they perforate it. So that's generally where it's around. Now, obviously, chronic constipation and increased intraluminal pressure is a big risk factor associated with these particular diverticulars. So the sheer presence of a diverticular can be called diverticulosis as well. Now they can be quite small, or you can end up with a giant diverticulum as well, which is quite dangerous. Now if these diverticulars actually get inflamed, you'll end up with a diverticulosis. Now one of the complications that can occur from that is obstructions and perforation. So that's when we look at the picture on the right hand side. A lot of these things are complications associated with diverticulars, and in particular diverticulitis. So because of the inflammation presence, we end up with stenosis. The weakening of the wall can cause fistulas, and a chronic inflammatory state ends up causing fibrosis. So it ends up changing the morphology of the actual bowel, making it a lot harder for feces to pass through. On top of that, we can have ruptures of small vessels, causing hemorrhaging, and you can also rupture the bowel, causing it to leak into the peritoneal cavity as well. Now, when we talk about colon cancer, we have a lot of theories of what causes it, but we're not actually sure again. So we're looking at genetic factors. There's a lot of genetic factors playing a role in this. And we've also found a link with diets associated with high sugar, high fat, and low fiber. Now, colon cancer mostly affects the large intestine. Okay, so when you are talking about colon cancer, it's associated with the large intestine. Now, the signs and symptoms depends a lot on the size, the shape, and the area of the actual cancer formation itself. So if we're talking about the right side, and this is the patient's right side of the bowel, then you usually end up with larger masses, but not a lot of symptoms. Long-term tumours, especially ulcerated tumours, can lead to anemia, whereas the left-hand side, you'll end up with ring-like lesions. So it actually travels around the bowel itself as opposed to being in just one area. And this is associated with obstruction, complications, and blood. So bleeding of blood in the stool. Now, like most of the other cancers of the gastrointestinal system, it has a huge chance to metastasize, and it can move into other areas of the bowel. It can go into the lymphatic nodes, okay, the pilus patches associated with it, spread through the body. It can easily get picked up in the liver, portal circulation, and it can end up in the lungs, places like that. Now, screening for it's pretty simple though. You can just do a fecal occult blood test. If you have fecal occult blood, then you need to be fully diagnosed with a biopsy of the area, just to let you know. Alright, we'll finish off really quickly for the intestinal side of the house with obstructions. Now, two main causes of obstruction are either your paralytic, so this is where you paralyze the muscles of the bowel. So abdominal surgery is common because if you end up playing with it, stretching it, the muscles get fatigued and they don't work for a little while. But you also have your peritonitis and your spinal cord injuries as well. Now, the main one that we're mostly associated with is our mechanical obstructions, and this is where there's a foreign body. So the presence of constipation, gallstones, or tumours can cause that. But you can also get different types of twisting of the bowel, where the bowel will loop into itself in herniation. You can get intussusception, which is a difficult one to say. That's what B is showing you. And you can also get conditions where the bowel will adhere to other parts of the bowel, and it also can be associated with tumour formation. So that is your intestinal obstruction. So like I mentioned, we talk about it a lot, but I'll just mention common signs and symptoms. So colicky abdominal pain, so really big pressure baroreceptor type pain. Constipation, sometimes complete constipation with overflow can be noted, as well as abdominal distension and vomiting at times can also be your signs. Okay, moving on to your associated organs for the digestive system. We'll look at the liver first. It's a very important organ. Okay, its blood supply is pretty damn amazing, quite unique. It's fed by the arterial hepatic artery, and it's also fed by the venous hepatic portal vein as well. So we have a large amount of blood coming into it, and then it ends up in the inferior vena cava, straight to the heart. So all things that are metabolized get picked up first. It's associated with the synthesization of proteins and nutrients. It also produces bile and is a main storage house of our glycogen too. So when we start looking at pathology of the liver itself, an easy way to look at it is different stages of alcoholic liver disease is a good way to cover off on all of the disorders that can happen in the liver. So obviously not every single one of them, but the big main ones and the pathological patterns that can occur can be covered off with your alcoholic liver disease. So I'll just cover that one first. So the way alcoholic liver disease works is we all know that alcohol is a toxin. Okay, so as you start to drink and you get exposure, you'll end up with steatosis. Okay, now that basically means that the liver comes under a little bit of stress, so it has a disruption in its normal energy metabolism. So because of that, it starts to get quite fibrous from scar tissue and also store fatty deposits. So you end up with a fatty liver itself. Okay, so that's just a nice easy one. We'll talk a little bit more about it in a bit. As you keep drinking and you keep moving on to exposure, then you'll end up with things like your hepatitis as well. Now both of these are reversible, okay, and they can go back to a normal liver. But if you keep hitting it with large amounts of binge drinking or constant drinking, then you'll end up with a cirrhosis as well. Okay, so looking at the first side of the house, we'll look at our hepatitis. So caused by a severe exposure. Now that would be associated with your acute hepatitis, but it can also be linked into chronic side of the house too. So alcohol is what's known as a non-infectious cause of hepatitis. Now certain drugs can be another one as well. Now your viral or your infectious side of the house is usually hepatitis A, B, C and E are your main viruses that cause it. Now when the liver goes through hepatitis, what happens is the localized inflammation causes liver cell necrosis. Okay, and then at the same time you get an infill of fluid, so the edema actually causes the liver to stretch, and that's where you end up getting your liver pain as well. Now if hepatitis is maintained for a long period of time, usually got to do with infections, then you can start leading to carcinomas, cirrhosis, or even liver failure itself. Okay, so just know that hepatitis isn't only associated with the classic viral conditions. Now, looking at our steatosis, as I mentioned, that's the accumulation of fat linked to alcoholism, but also it can be linked to obesity and malnutrition as well, believe it or not. And one you've got to do with the abdominal pressure is associated with pregnancy. Good thing about it is if you have a scan and have a fatty liver, is it can be reversed by eliminating whatever the cause is. Okay, now in case of pregnancy, just waiting is a good way to eliminate pregnancy as opposed to the alternative. But obesity and alcoholism is obviously a nice easy one that can be changed, otherwise you'll end up in your cirrhosis. Now, cirrhosis is best defined as a loss of normal liver architect, okay, so therefore function as well, and you'll end up with a fibrous divide within the liver as well. Okay, now the way that works is the area that is all fibrous is dead, non-viable, and you'll end up with regenerating nodules as well. Okay, so it can, part of it can be irreversible. Okay, so once you get a good case of cirrhosis, it can be irreversible. So alcohol is a good cause. The viral hepatitis B, C, D are some other causes as well. And you also have chronic obstructions of biliary, and then hemochromatosis can also be a cause of your cirrhosis as well. Now, the way to know if you have cirrhosis is you've got to look at the larger pictures. Okay, so some of the larger systemic signs are you'll end up with either a small liver on palpation or a large one. You'll have associated jaundice on appearance or in urinalysis and blood tests. Transitional fluid shifts is common, so you end up with oedema. And you can also, males can end up with gynecomastia as well because of the storage of fat, because you no longer have a liver that can take care of it. Now from there, you can easily end up with carcinomas, so liver carcinomas, hepatic failure, and portal hypertension as well. So portal hypertension is best described as a back pressure build-up of the portal veins. So as a result of fibrous tissue or nodules obstructing the actual liver flow, we get this backup of pressure. So it increases the hydrostatic pressure around the body. Okay, so the portal circulation is quite a large circulation, and part of the complications that we can get from that is a condition known as ascites, so actual fluid leaking into the peritoneal cavity. You can get splenomegaly, so your spleen just gets overloaded with blood, and therefore hydrostatic pressure moves into the spleen, and it's just too great, so it ends up getting quite large as well. Now, on top of that, you can also get a whole bunch of circulatory problems as well. Okay, so you're going to end up with obviously pockets of hemorrhage, esophageal varices and gastric varices that I talked about. But then you can also have what's known as a periumbilical varices, which is your caput medusa. Now, the reason it's called that is because on clinical appearance, it actually looks like you have like varicose veins underneath the lining of your skin. So it looks like you've got a bunch of snakes crawling under there, so they've named it after Medusa. Okay, another one associated finally with the liver is your choleliosis. So choleliosis is the formation of gallstones. So this can happen usually from obstruction, poor diet, high minerals, and poor flow of your actual gallbladder itself. You can have choleliosis without any symptoms at all, but once you start getting symptoms, then you'll get abdominal pain, usually associated with fatty meals because there's no bile coming into it. You can get jaundice because the jaundice that is usually pumped into the digestive tract for excretion is no longer there. Now, in the presence of inflammation only, so inflammation and damage, you will get a fever. Now, when you have a fever and the associated choleliosis, it moves into cholecystitis itself. So cholecystitis is the inflammation side of the house, and that's the only way that you're going to get a fever from there. Now, another thing that can happen is a stone can pass through and end up blocking the biliary duct itself. So you can end up with biliary cirrhosis and transitional fluid shifts as well. Okay, the last thing that we will talk about is the pancreas. So the pancreas is a pretty impressive organ, to tell you the truth. It is mostly what's known as an exocrine organ, but it also has a small amount of endocrine function. So the two different cellular formation is everything associated with exocrine is called your Purkinje cells. Okay, so Purkinje cells or Purkinje cells are associated with the secretions of pancreatic juices. Okay, so proenzymes, bicarbonates, and enzymes themselves is from that. Whereas your islets of Langerhans, they're associated with your endocrine side of the house. Now, the picture in front of you leading to acute pancreatitis is just looking at the causes and the mechanisms associated with exocrine pancreatitis. So we haven't even looked at the effects that it would have on hormones, because they're quite obvious. Okay, but the causes of pancreatitis can be many. So if you just have a blockage to the pancreas, so the pancreatic duct or gallstones, things like that, then that's going to cause pancreatitis. A huge amount of toxins can cause cellular injury, so trauma, infections, lack of blood flow, drugs, alcohol, they can cause primary injury to the Purkinje cells. Okay, so that's and on top of that, if you have any metabolic injuries, okay, or a large amount of alcohol, it can also cause what's known as a defective intracellular transport, which ends up having pass-on effects to the enzyme activity itself. So each one of these particular causative agents, will end up in a dysfunction of the actual pancreas itself. So either by releasing too much of your proenzyme or lysosomal enzymes, which will end up causing more destruction to the pancreas, because that's what they do, or having an impaired blood flow, which will cause ischemia. Either way, what will end up happening is you'll end up with actual cellular injury of the pancreas. Now, when that happens, we get a huge amount of inflammation, and with that inflammation, a large increase in hydrostatic pressure, which leads to your edema. Okay, now your proteolysis also occurs because of the influx of all these proenzymes and lysosomal hydrolase, they end up breaking down proteins. Okay. We have an increase of lipase initially, which breaks down a lot of fatty tissue, and then we can end up having hemorrhage as well, because we have an increase of intracellular enzymes that are used to break down elastin. So it actually ends up breaking down the walls of elastin. So you end up with all these symptoms, and that is associated with acute pancreatitis. So you end up with severe epigastric pain that radiates right through to the back. Okay, so from the front right through to the back. A lot of nausea and vomiting because of the filling of the stomach with all these activated enzymes. You look like shit. You absolutely do. You look like death, and the mortality rate of pancreatitis is immense. Okay, think of it as having a massive influx of specialized chemicals that are designed to dissolve your body. Okay, that's what acute pancreatitis is all about. Okay, so we can end up with hemorrhaging, third-shaped shifting in the peritoneal cavity can cause your hypertension. You can get your peritonitis. You can get necrosis and pseudocyst formations, and on top of that, you can end up with hyperglycemia if the islets of Langerhans cells are destroyed as well, because then you'll have no insulin being produced. Now, in the event that this acute pancreatitis hangs around long enough, you'll end up with your chronic pancreatitis. Now, this is obviously the result of a chronic inflammation process and associated with irregular fibrous replacement of normal pancreatic cells. Okay, so unlike the influx of destruction side of the house, we actually have a replacement of functional cells by dysfunctional fibrous mass. Now, this particular disorder is more associated with chronic alcoholism or long-term obstruction, tumour, scarring of your pancreas as well. Now, you can obviously have a hereditary autoimmune link, as most things do, but the difference is your features of this one is you can end up with what's known as a nerve entrapment. So part of the head of the pancreas wraps around a nerve, so when that goes into fibrous, then you end up with nerve entrapment, and that causes stenosis of the duodenum and obviously pain. Now, exocrine insufficiency is the main one when we're dealing with chronic inflammation. Unlike the other one, which was just an influx of everything as a result of a acute, now we have fat malabsorption. Okay, we have malabsorption of our fat-soluble vitamins, malabsorption of proteins, as well as your endocrine insufficiency, which obviously ends up with a whole bunch of pseudo-diabetic mellitus type symptoms. The pancreatic characteristics is you have stenosis, fibrosis, pseudocysts, and calcification forming all over the pancreas itself. Now, as a result of mostly chronic pancreatitis and associated risk factors that cause pancreatitis, you can end up with pancreatic cancer. Now, the most common place to get it is at the head of the actual pancreas itself, and the largest risk factor is smoking, alcohol, high fats, diabetes, and obviously having your chronic pancreatitis. The differences in signs and symptoms is just mostly long term. Okay, you're really not going to know too much difference, especially if you started with chronic pancreatitis and then moved into pancreatic cancer. They're quite similar, but depending on where the size or the shape of the tumour is, you can get obviously weight loss, loss of appetite, nausea, vomiting, very simple. But if the biliary duct or the cancer is associated with the biliary duct, you can get associated jaundice as well. Well, that is GIT Pathophysiology in a nutshell. Like I said, infinitely more to go through. In the past, this is more of just a broad overview of all the structures. I may do more focused pathophysiological lessons in the future, but until next time, take care.